most evil phenomenon that affects mankind today, and that's cancer. If you are a man alive today, the National Cancer Institute in the United States says 1 out of 2 of you will have cancer in your lifetime. And if you're a woman, 1 out of 3 of you will have cancer in your lifetime. So that means that if it's not you, it's certainly going to be someone you know, someone you love, that gets this disease. You can go to the best doctors at the best medical centers in the world, or you can go to the country doctor in the corner. They all have the same chemotherapy, drug poisons that you're going to get. Cancer affects every aspect of life that is enjoyable. There has to be something different to be able to attack this disease than what's available now. We have chemotherapy, we have radiation, we have surgery that I'll talk about, but none of these treatments are curative of metastatic cancer. Why? Because the cancer is a microscopic disease, and the surgeon's scalpel cannot be specific enough to get down to that single cancer cell in order to cure the disease. Chemotherapy and radiation, the same. Those therapies, they can reduce the amount of disease in some cases, but they don't eliminate the last tumor cell. If you don't eliminate the last tumor cell, the tumors come back. And generally when they come back, there's no treatments left and they're lethal. Immunotherapy is where many of us in the field believe if there's going to be a cure for cancer, it'll be an immunotherapy. Because the human immune system is designed to be able to identify unwanted microscopic disease wherever it resides in the body and eliminate it. But we have not been successful in harnessing the known power of the immune system to be able to protect us against human cancer. Why all the past immunotherapies that have been tried have failed? So the first is the assumption that cancer is a disease of a weakened immune system. If it were, then patients that have suppressed immune systems should have a higher incidence of cancer. It's only logical. Transplant patients, patients taking immunosuppressive drugs, AIDS patients, do they have a higher incidence of cancer? The second basis of developing immunotherapy drugs is the concept that cancer is a disease that is derived from our own bodies. All of these types of immunotherapies are based on this concept that we must make the cancer look foreign. If it were true that the immune system was ignoring the cancer because it was part of ourself, then we would expect that when we looked inside of tumors, there shouldn't be any congregation of immune cells. Now, I've looked at tens of thousands of biopsies in my career, and almost always in these biopsies, there are immune cells. When I joined the faculty at Hadassah University Medical Center in the Department of Bone Marrow Transplantation, we are able to witness and see something that actually does work. An immune response that actually has curative potential against human cancers. It's called the graft versus tumor effect. This is a CT scan of a woman with breast cancer where the breast cancer has invaded the liver. This is a liver. It's hard to tell what is liver and what is tumor. It's so full of tumor. After the researchers gave or transplanted immune cells from this woman's sister to her, the liver completely cleared of all of the tumors. this isn't a one-time observation. This is an observation that occurred over and over and over again in not every patient, but in a majority of the patients. Unfortunately, those same immune cells that are transplanted that can kill the tumors, they also indiscriminately will kill normal tissues and organs, causing a disease called graft versus host disease. It's a horrible, horrible way to die. So not very practical way to treat cancer, but very interesting to ask the question, why is it that someone else's immune system transplanted into the patient will kill that patient's tumor, but the patient's own immune system won't? If we were able to understand that, then we could harness that power and we could develop a drug that would have the same mechanism. That was the idea of immunovative therapies when we started. I had access to all these patients that are undergoing this procedure, and I took blood samples from them and developed immunological tests so that I could understand step by step what happens. Why is it that the transplanted immune system kills the cancer, but when we boost the patient's own immune system, it ignores the cancer? We knew that if these are the transplanted cells, they're called allogeneic, meaning coming from another human being, that these cells mediate both effects. This is the graft. The graft attacks the tumor, called the graft versus tumor effect, the beneficial effect we want. They also, unfortunately, cause the detrimental graft versus host effect. If you could separate this beneficial effect from this detrimental effect, you would have a very powerful therapy. Unfortunately, we have not been successful very much in separating the effects because the two effects appear to be very interrelated and maybe even caused by the same cells. So you can't separate them. So we thought, well, maybe instead of separating the two effects, that we leave them interrelated, but we reflect these effects onto the patient's own immune system so that we have what's called a mirror effect. In the mirror effect concept, we develop an allogeneic cell that stimulates the host immune system to reject the graft in an effect where this host cells reject the graft, host versus graft. The host versus graft is the opposite of the graft versus host. The difference is when the host immune system rejects the graft, it's not toxic, as when the graft rejects the host. So we develop all of the immune signals that come out of rejection, we cause by having the immune system reject the graft, and that allows the host immune system now to attack the tumor. Somehow I convinced the Office of the Chief Scientist in Israel to invest $300,000 into testing it to see if it would work. And throughout these trials, what we did is we developed our actual roadmap that showed the cascade of events that occurs in a patient that is undergoing curative graft versus tumor immunity. And then we would look at the cascade of events that occurs in patients that don't. And we would be able, by a process of elimination, to define the pathway that is required to have curative immunity. Then we developed a drug, a bioengineered graft. And so we were able to develop a process where we could take blood from normal blood donors, any blood donor, put it through a 9-day process, and out the end comes out these special immune cells that don't exist in nature, so we can patent them, which have all of the features that we've previously determined are necessary to have an anti-tumor effect. This is the drug. It's called Allostim. And last September 2009, we got approval from the United States FDA to initiate our first human clinical studies to determine how this might work. We tested a lot of monkeys, and nothing happened. Finally, the FDA said, okay, we'll let you try this in humans, but not any humans. Only hospice-level cancer patients with 60 days or less to live that have tried every known available therapy and are at the end of the line, and basically they're going to die anyway, so those patients you can try. Absolutely the worst kind of population to try an immune therapy. I get the patient after they've been bombarded with chemotherapy and radiation, and they have no immune system left, and they have no energy because they're not eating, and they're in wheelchairs, and they're full of pain medicine, and just in a really difficult shape. We treated 42 patients. They all they had a variety of different types of metastatic cancer. The majority of them were breast cancer patients, 14. The next highest number was colorectal, but a variety of different types of cancer. Age was average 61 years old, I think pretty young. So the average ECOG status of the patients that walked into our clinic was 2.2. So these are very unfortunate and sick people that are coming to our clinic. They have a huge amount of tumor in their bodies. We were anticipating the worst. But this is what really surprised us, is in this kind of population of patients, we had this tail of patients, about 20% of them, that are long-term survivors. We bring you through this story of patient number 1. At 90 years old, he developed colorectal cancer. He went through all of the standard treatments. He had 11 metastatic tumors in his liver. He went into liver failure, and he came to us. Now, we treated him with our therapy, and he came back 60 days later for his scan. And you can see from the scan that it's very clear to see now. You see very big, scary looking tumors in this CT scan that radiologist called and said, this gentleman has massively progressive disease, and you better do something. The therapy didn't work, and he's going to die soon. And we waited for him to come to the clinic. He walked into the clinic, and he was smiling and telling us, I walked the dog today, I did my garden. And he told the story. He said, the most important thing is I went back to my company where my 2 sons were plotting that I was gone, and I came back and I took control. He just looked great, and he was in liver failure at this point, and now his liver enzymes are near normal. So it didn't make sense. Why does his skin look so scary, but the patient looks so great? And this became the theme of the whole trial. That patient after patient had this kind of presentation. What looks to be a big, huge tumor is actually not tumor at all. It's scar tissue. This is fibrosis that was around making the tumor look very big. And this, interestingly, is coagulative necrosis. That's what happens when the immune system cuts off the blood supply to the tumor. You get coagulative necrosis, and there's a little bit of dead tumor left mixed with some immune cells. There is also some alive tumors. So we didn't totally cure this patient, but the point is that the total amount of tumor was way overestimated by the radiology. And this is why the patient probably got better. We also developed evidence with PET scans. In PET scans, the dark lesions here show metabolic activity that generally correlate with metastatic lesions, and so this patient appears to have quite a bit of activity in the liver, also in the bones, and you can see how there's a change on cleaning up that particular patient's PET scan that probably looks very familiar to this gentleman over here. It happens to be his wife. This story of this woman, this is a 64-year-old woman with breast cancer. And when she came to the clinic, she says, you know, Dr. Har Noy, I know I'm going to die. And I don't think you're going to be able to cure me. But But the one thing that I really want, and the reason I came to the clinical trial, is because I have these ugly, horrible lesions outside my body of tumor with rotting, stinking flesh. And she said, my grandchildren, they won't come near me because grandmother stinks. And she said, is there just anything you can do to make those lesions stop smelling so that I can hold my grandchildren before I die? So obviously a very touching situation. But she came back at 60 days. You can start seeing some of the black. This is tumor that's dying. And in a very short period of time, remarkably, we could watch with our own eyes as this tumor started to fade and eventually go away, and also the smell went away. This woman is still alive at 21 months. What we have here is an immune therapy that for the